Now we speak about combined oral contraceptive pills, which is very important and can use for contraception and for treatment of other gynecological disease rather than its contraceptive benefit. Combined contraceptive pills contain both estrogens and progestogens. The estrogens either are high or low doses. The high doses give more protection but high risk of thrombosis. The doses as 50 or 35, 30 or 20 milligram per day, taking in a form of ethinyl estradiol or mistranol. While progestogens, which has different generation, either first generation northinodril or second generation levonorgestrel or northestrone, or third generation, which is the desogestrel, gestodine or norgestimate, and fourth generation is drospirenone, which is available in a brand called Yasamine. It has anti-mineralocorticoid and anti-androgenic effect. Also progestogens available in form of norgestromine in a brand called Ibra, used as a patch. The third and fourth generation progestogens have less androgenic, therefore they are used in treatment of acne or hirsutism, but they have high risk of thrombosis. Therefore, the female who has a risk of thrombosis should not take the third or fourth generation progestogens. Mode of action of combined oral contraceptive pills are by suppression of ovulation by inhibition follicular-stimulating hormone and luteinizing hormone. Also act by adverse effect on cervical mucus. They cause thickening of the mucus that prevent the ascending of the sperm to the uterus. Also they has effect on endometrium as they suppress the growth of the endometrium, so prevent implantation. And this picture demonstrates the differences in the endometrial growth and hormonal levels between the women not taking contraception and women in the beginning of the pregnancy and women taking combined contraceptive pills. In women who are not taking contraception, mean the normal menstrual cycle, the endometrium in the first day of the cycle are shed because there is a low level of the estradiol and the progesterone, and this low level of this hormone will stimulate elevation of follicular-stimulating hormone that lead to the growth of the Gravian follicle and then ovulation, and the elevated hormone in the luteal phase due to corpus luteum formation will lead to more maturation of the endometrium for preparing for the implantation of the fertilized ova. But if the pregnancy not occur, the shedding of the endometrium will occur. While in the beginning of the pregnancy, after the ovulation, there is fertilization of the ova and implantation, and the implanted embryo will have a primitive placenta which will secrete human chorionic gonadotropin, and this is hormone is very important for supporting the luteal body. So the luteal body is protected from regression and it will secrete more estrogen and progesterone, and this hormone will lead to more maturation of the endometrium and protect the pregnancy, and this elevated hormone will support the pregnancy and endometrium and prevent miscarriage. While in the women who taking contraceptive pills, the estrogen and the progesterone are in constant level that will lead to inhibit luteinizing hormone and follicular-stimulating hormones, so there is no growth of the Gravian follicle, and the inhibition of growth of the follicle will lead to suppression of the release of natural estrogen and progesterone. So there is no growth of the endometrium, lead to its atrophy. So the pregnancy will be prevented because there is no growth of the follicle and no ovulation, and there's atrophy of the endometrium, in addition to the effect of the contraception on the cervical mucus that prevent ascending of the sperm to the uterus. The combined pills that contain estrogen and progestogen are of different type depending on the concentration of the hormones in the pills. These are either monovasic pills, which are 21 pills contain constant levels of estrogen and progesterone in all pills, while the triphasic pills, which also contain 21 pills but are divided into 3 groups. Each group contains 7 tablets. Each 7 tablets contain different doses of estrogen and progestogen. These are manufactured to be mimic the natural levels of steroid hormone during the menstrual. The benefit of that is to prevent withdrawal bleeding that may occur in some women that take monovasic pills. This brand contains pills divided into 3 groups and different colors. So the first 7 pills has doses of estrogen and progesterone different from the second group, and this second group is different from the third group. In monophasic and triphasic, the patient take the first tablet either in the 3rd or 4th or 5th day of the menstrual bleeding, and take 1 pill each every 24 hours until complete 21 pills, and then the patient take a break of 7 days before the starting the next bucket. The last type of the pills is called everyday pills, contain also 21 pills. All white pills, as you see in this brand, contain same dose of estrogen and progesterone, while the red pills, 7 pills, contain iron only, mean they are free from the hormones. They are called placebo, but sometimes called free pill. In this brand, the patient take the pills started as the monophasic and triphasic, and when complete the 21 pills that contain hormone, she continue and complete to take the placebo pills, and after complete the placebo, they start the next bucket. Adverse effects of combined oral contraceptive pills are venous thromboembolism, myocardial infarction, hypertension, decreased glucose tolerance, increased risk of stroke in women with focal migraine, headaches, mood changes, cholestasis, jaundice, increased incidence of gallstones, precipitated porphyria. Contraindications for using combined oral contraceptive pills mean absolute contraindication. These include age more than 35 years and smoking, but if the patient not smoking, it should not take after 40 years of age. Blood pressure more than 160 over 100 mercury, hypertension with vascular disease, deep venous thrombosis, current or past history, also current or past history of myocardial infarction or cerebrovascular accident, also not used in multiple serious risk factor for cardiovascular disease, or also known thrombogenic mutation like factor V renin deficiency, also not used in current breast cancer. Drug monitoring before commencing contraception with combined oral contraceptive pills. A proper evaluation of risk factors needs to be carried out. Monitoring of blood pressure and inquiry about other adverse action of the pills should be continued over the period of prescription. Miss World Guideline adapted from the Faculty of Sexual and Reproductive Health Care stated at 2011 the patient should be consulted and educated if she is missed pills during her treatment. If patient missed 1 pill, mean more than 24 hours, and up to 48 hours late, mean less than 48 hours, she should continue contraceptive cover by the missed pill should be as soon as it is remembered. The remaining pills should be continued at the usual time. And in order to minimize the risk of pregnancy, the emergency contraceptive is not usually required, but may need to be considered if the pills has been missed earlier in the bucket, mean in the first 1 to 7 pills, or in the last week of the previous bucket. But if the patient has forgot 2 or more pills, mean more than 48 hours late, continuing contraceptive covers by the most recent missed pill should be taken as soon as possible. The remaining pills should be continued at the usual time, and the barrier method contraception like condoms should be used, or avoid sex until 7 consecutive active pills have been taken. And this advice may be overcautious in the 2nd and 3rd week, but the advice is a backup in the event that further pills are missed. And to minimize the risk of pregnancy, if 2 or more pills are missed in the first week, mean in the first 1 to 7 pills, emergency contraception should be considered if the unprotected sex occurred in the pill-free interval or in the first week of pill taking, which means if the patient forget 2 or more pills in the first week, or she had unprotected sex in the break interval, she should take emergency contraception in the form of oral high-dose progestogens or intrauterine copper device. But if the pills are missed in the second week, mean in the pills 8 to 14, no indication for emergency contraception if the pills in the preceding 7 days have been taken correctly, assuming the pills thereafter are taken correctly and additional contraceptive precautions are used. But if the pills are missed in the third week, mean pills from 15 to 21 pills, she should omit the pill-free interval, mean she should not take a break from the pills, or discarding any placebo tablet and starting a new pack the next day in order to prevent pregnancy. The risk of missing contraception can avoid it, especially in the patient who has usually difficult to remember to take her pills by giving her combined contraceptive hormones by a route of like a patch or a vaginal ring. In the patch, the patient with the first batch in the 3 or 4 or 5 days of menstrual bleeding, and each batch put for 1 week, and the second batch for another week, and the third batch for third week, and the fourth week it is a batch free, mean take a break. Then in the next week she put another batch, while in vaginal ring the patient applicate it for 3 weeks, and in the beginning of the fourth week it is removed, mean 1 week for break, and after ending of the 1 week break she can insert another vaginal ring for the next month. Combined oral contraceptive pills drug interaction. Combined oral contraceptive pills undergo metabolism by both phase 1 and phase 2 hepatic pathway and are affected by cytochrome enzyme. Cytochrome enzyme inducers drugs like rifampicin, carbamazepine, and Stephen Johnson wort. Other drugs like antifungal, including glazofulbine, and some types of antiretroviral drugs lead to this effect. So these drugs will lead to an increased metabolism of combined oral contraceptive pills, so decrease their level in the blood and lead to decrease its action, and pregnancy may occur. Use of broad-spectrum antibiotics like ampicillins or doxycyclines can result in reduced efficacy due to effect on intestinal flora, which are very important for metabolism and absorption and recycling of contraception. Now we speak about the mini pills, which mean progesterone only pills, which are 28 days of progestogen. The mode of action are inconstant inhibition of ovulation, means sometimes there is inhibition and sometimes there is no inhibition of ovulation. Therefore, it has a high failure rate, and also a patient at risk of developing simple ovarian cysts and has a risk of irregular vaginal bleeding. Other action is by adverse effect on cervical mucus and adverse effect on endometrium. Because inconstant inhibition of ovulation, it will lead to irregular vaginal bleeding, so poor cycle control. This example of mini pills, which contain 28 pills, so the patient take this and after finish it, take the next packet immediately, mean there is no a break when using mini pills, because there is a high failure rate of these pills, so the patient should not take a break from contraception, mean she should start the next packet immediately. This is another type of progesterone only pills, which is cerazide. Cerazide inhibits ovulation and it contains third generation progesterone, which is desogestrel. Its action including also thickening of the cervical mucus and endometrial atrophy. So this type of contraception, it has high risk of thrombosis, therefore should not be prescribed for the patient has risk of thrombosis. Other type of progestogens are medroxyprogesterone acetate, depo-provera, or etinogestrel, which take as female implants, implanon, male implants, or vaginal ring. Vaginal ring act for 28 days, and when it's removed, it should apply the next ring immediately, mean there is no break. Medroxyprogesterone acetate, depo-provera, which contain 150 mg and it is taken intramuscularly. Another type of injection is lower dose formulation of the micronized progesterone called cianobreast, which contain 104 milligram and taking subcutaneously, and this type of injection is suitable for the patient who taking anticoagulant like heparin or warfarin to decrease risk of hematoma that occur in deep intramuscular injection. And it's also easy to taking by the patient, so no need for medical staff for administration. Both injections act by inhibiting the ovulation and thickening of the cervical mucus and endometrial atrophy. And they are taking every 12 to 14 weeks, mean every 3 months. So it is easier to use, but its side effect is lead to severe hypoestrogenemia and may lead to menopausal-like symptom and lead to osteoporosis and delaying and retaining fertility after the last injection, which may take 1 year before the patient to assume her ovulation and get a pregnancy. Another route of taking progestogens is by implant. This is the implant, and this is the applicator of it. Is a single root nixoplanon, contains 68 milligram of free keto-desogestrel, is a metabolite of desogestrel. It acts by inhibition of ovulation in addition of thickening of the cervical mucus and endometrial atrophy. Providing contraception for 3 years. Is a flexible root similar in size to the matchstick and is inserted subdermally 8 cm above the medial epicondyle, usually of the non-dominant arm. It's very effective. Its maximum action starts 7 days after application. The failure rate of this contraception is very low, and after removal, the steroid hormone level normal level after 7 days and fertility reassumed immediately. Progestogen releasing intrauterine system, which is the 52 milligram levonorgestrel intrauterine system called Marina. It is used for 5 years. Another type is Progestasert, which is used for 3 years and contains less dose of progestogen. The levonorgestrel intrauterine does not prevent ovulation, but it impairs cervical mucus and inhibits implantation. The most notable non-contraceptive benefit of the Marina is that of reducing menstrual bleeding. It reduced by 90% at the 12 months. It is also effective for treating dysmenorrhea, pain associated with endometriosis and adenomyosis, and protecting the endometrium against hyperplasia and carcinoma. After we finishing the speaking about the contraception, now we speak about postmenopausal hormonal replacement therapy. So the indication of hormone replacement therapy are to improve menopausal symptoms, which are vasomotor symptoms, sleep disturbance, improve performance during the day. Also to prevent of osteoporosis, as this hormone increase bone mineral density and reducing incidence of fragility fractures. The hormone replacement therapy for this indication not recommended for women above the age of 50 years. Hormone replacement therapy used for lower genital tract symptom, which including vaginal atrophy. Hormone replacement therapy used for lower genital tract symptom that due to vaginal atrophy, including dryness, soreness, and spermioneme, pain during sexual intercourse. Hormone replacement therapy has protective effect if started early in menopause, mean before the age of 54 years, or sometimes the hormone replacement therapy used in perimenopausal period for the patient who develop sign symptom of menopause before she get menopause, mean before her menstrual cycle stopped, or sometime in the patient who has premature ovarian failure at the age of 30 or 35 years, she get menopause early in her age, or sometime are used in patient who has no functional ovary like Turner syndrome. The prevention of cardiovascular diseases is not currently a licensed indication for hormone replacement therapy, mean the indication of hormone replacement therapy for the above indication not are used for specific prevention of cardiovascular disease. The steroids used in hormone replacement therapy are estradiol in form of valerate, enanthate, micronized estradiol in a dose of 1 to 2 mg per day, or Premarin in a dose of 0.625 to 1.25 mg per day, and the progesterone, including medroxyprogesterone acetate Provera tablet, contain 5 mg or 10 mg per day, nordasterone or dofestone. Other progestogens can use in hormone replacement therapy are levonorgestrel in the form of marine dihydrogesterone, or drospirenone or macronized progesterone. Testosterone has traditionally been given to the women with disorder of sexual desire and low energy levels who have failed to respond to the usual hormone replacement treatment. Combined hormone replacement therapy, taking orally or transdermally or by implant, transvaginal or by nasal route. The combined hormone replacement therapy given either sequentially or on continuous maneuver. The sequential combined mean the patient take estrogen for 28 days and in the last 12 or 14 days add progesterone. While in continuous mean the patient take the estrogen and progesterone for a total 28 days, which is the benefit of sequential over the continuous combined. The sequential sometimes given to the patient who has side effect from progesterone, so give progesterone for less day in the cycle treatment in order to prevent its side effect. Contraindication for hormone replacement therapy. The absolute contraindications are suspected pregnancy, breast cancer, endometrial cancer, active liver disease, uncontrolled hypertension, known current venous thromboembolism, also known thrombophilia factor 5 Leading deficiency, and in osteosclerosis. While relative contraindications are uninvestigated abnormal uterine bleeding mean undiagnosed uterine bleeding. The hormone replacement therapy should not be used in undiagnosed bleeding due to potential masking of symptoms of underlying endometrial diseases. Also, hormone replacement therapy relatively contraindicated in large uterine fibroid to prevent more growth of the fibroid, and in patients with past history of benign breast disease, also unconfirmed personal history or strong family history of venous thromboembolism, chronic stable liver disease, and in migraine with aura. Risk and side effects of hormone replacement therapy are venous thromboembolism, breast, ovarian, and endometrial cancer, increased risk of ischemic stroke, increased risk of coronary arterial diseases if combined hormone replacement therapy started more than 10 years after menopause, nausea and vomiting, abdominal cramps and bloating, weight gain and fluid retention, breast tenderness, impaired glucose tolerance, mood changes, altered serum lipid profile. This side effect including side effect of estrogen and progesterone. Metabolism and half-life of hormone replacement therapy. The half-life highly variable depending upon formulation used. They metabolize in the liver and excreted in the urine. Monitoring. Full medical history and physical examination should be performed prior to initiation to identify women at risk of adverse effects. Routine clinical monitoring for side effects, including advice to attend national cancer screening programs. Drug interactions reduce the clinical effectiveness if concomitant use with cytochrome P enzyme inducer like anticonvulsant and rifampicin. Important points that should be remembered when prescribing hormone replacement therapy are: the choice of hormone replacement therapy is depend on risk of adverse effect and individual preference. In non-hysterectomized women, progesterone may be given cyclically mean for 12 or 14 days of the cycle to induce withdrawal bleeding. Alternatively, progesterone can give continuously. Women with history of endometriosis should use combined preparation even post-hysterectomy due to ectopic endometrial tissue. Mean the patient if has uterus or has endometriosis should has combined hormone replacement therapy, but if she has hysterectomy, estrogen replacement therapy is enough. Subcutaneous implants are associated with the recurrence of vasomotor symptoms at supraphysiological concentrations and prolonged endometrial stimulation after discontinuation. Thank you very much for your attention.